Thank you, Mr. Chairman, Executive Director, board members. Saludo, Gobernadora Francisco. Welcome to the board meeting today. So just wanted to provide some context on the presentation you're going to hear today. Healthcare is instrumental to our island, and a critical component of healthcare is its workforce. For years, we have heard that there's a need for more doctors on the island, that we have huge gaps in particular providers, but data has been a challenge. Getting the right data to not just understand the gaps, but understand where the gaps are on the island and why do we have those gaps. So given the importance of having data to make decisions, not just in the public sphere, but also information that private stakeholders can make, last year we decided to do a study so we can better understand these gaps on the island. We did an RFP, and several firms submitted proposals, and we ended up selecting FTI Consulting to do the study. FTI has been working on the study for the last 6 months, and we finally have the final report that you'll see today. And in an effort to really understand where are the gaps and how big the gaps are, so we can make informed decisions about how to close them in the future. So you'll see representatives from FTI go through the report, the methodology, the findings, and some general recommendations that we're hoping we can start working with the government and the private stakeholders around how do we go about solving these gaps. So, Mr. Chairman, without further ado, the FTI consulting team.
All right. Good morning, everybody. Thank you for the opportunity to present this very comprehensive study. Thank you to the members of the board, the governor, chief of staff. I'm Juan Montañez. I'm with FTI Consulting. With me are, to my left, Dr. Susan Manning from FTI Center for Healthcare Economics and Policy, Maria Levis, the CEO of Impactivo, our essential partner on this project, which it required significant stakeholder engagement, which she led. And then to my right is Annie Mayol, also from FTI Consulting, who day-to-day led the team that worked for more than 6 months on this very extensive project. Briefly, to share a little bit about the study itself and the scope of it, it is impossible really to ascertain the challenges that we're having with Puerto Rico's healthcare workforce supply if we don't understand the demand for those services that the workforce is required for. So we started the project by modeling the demand for different healthcare workforce categories based on the needs of the population and the services that they were expected to require, not just now, but into the future, because we want to make sure that any recommendations were focused on the future needs of the population, not current needs, so that we try to stay ahead, not chase demand, but get in front of future demand. Then we looked at the workforce supply, and we took in data from more than 20 different organizations, almost 400,000 records from the licensing board, from insurance companies, from the government agencies that actually run healthcare programs, and assembled all that information to create as comprehensive and as credible a picture of the workforce supply as we could. Then we married those two data sources to ascertain the imbalance between supply and demand and focused on those categories of the workforce, whether it's physician specialist or other categories that might not be immediately apparent where we do have shortages, that might actually be as critical or more so than with some of the physicians, to be able to understand what those imbalances are, and then through a very extensive qualitative process, stakeholder engagement interviews, a survey, to try to understand what drives that imbalance. Why do we not have more workforce? And what are the underlying causes? And then based on that, we formulated recommendations. A couple of key points that I want to make. When we talk about supply, it's very important to recognize that supply is not purely a function of the number of physicians or the number of physical therapists or the number of lab technicians. You got to look at their availability, how available they are in terms of hours of operations, their capacity to provide services. Are they, for example, so burdened by administrative work that they don't have as much time as might be apparent for them to provide services or manage services? And then their accessibility. If they're located in the part of the island that makes it very difficult for the typical Puerto Rican to get to them, that becomes a challenge too. So you can not just rely on the hard numbers of how many of something we have. We got to look at all these other factors. And then there are a couple of critical assets that we turn over to the Oversight Board with the goal that this becomes, and I know it's a bit of a cliche, a living assessment, a living study, because this is going to be very dynamic. The workforce changes, the needs of the population might change. We created a workforce profile and a model that we'll describe in more detail throughout this presentation that hopefully can be used for continuing analysis. A very critical component of this project was the engagement that we did with the community as a whole. We talked to hospitals, we talked to insurance companies, we talked to associations that represent different critical constituencies within the healthcare system, and Maria can give you a bit more detail on that whole process.
Of course. In order to ground the study in Puerto Rico's reality, we made sure that we carried out extensive interviews with key stakeholders across all the groups that Juan just mentioned. This included over 70 key stakeholders and 22 organizations that participated not just to inform the questions that we were going to ask in the survey, but to also help us understand what drives the access issue, what complexities there are, and what viable solutions exist. Unanimously, the voices all mentioned that the situation is dire. And what you guys will see in the report does present a grim picture. I will add, we are at a tipping point. This situation impacts us all. So what we also saw was irrefutable commitment from all stakeholders to move beyond their interests in order to achieve solutions. We were even able to identify some solutions that could be put in place within a year.
Thank you. So let's talk about the findings. And yes, some of these findings might be a bit difficult in terms of painting a picture that might be a bit too negative, but we are independent. We do not represent any of the stakeholders in the healthcare system. Quite a bit of knowledge of the healthcare system in Puerto Rico, which we put to use on the project, but we were charged with presenting as real a picture as possible, not just of the challenges, but also identify potential ways to correct these problems. And it'll be multiple solutions that will have to be implemented in a very coordinated way to get us out of this predicament, but we can get out of it. But we gotta understand what the situation is. So with that, we're gonna go over the key findings of the study, beginning with Dr. Manning.
Thank you. I will say from an economics perspective that the inability of a jurisdiction to not have sufficient workforce in order to meet the healthcare needs of its population not only productivity and ability to track economic development. Our approach was very principled. We did not simply do what you would call sort of a trend of what the workforce looks like today and what it would look like tomorrow. We, in fact, did a sort of grounds-up approach, looking at the population characteristics, including the age characteristics and the declining population in Puerto Rico. We also looked at demand characteristics. We looked at the health status of individuals within the Puerto Rico economy. We looked at their social vulnerability, and we also looked particularly at the disease prevalence. And it was the disease prevalence and chronic conditions within the economy that really drove our analyses. In Puerto Rico has very high incidence of high blood pressure, diabetes, asthma, heart conditions and heart attacks, and chronic kidney diseases. And this really impacts the type of physicians that you need on the island and need to recruit in order to resolve today by 21 categories of healthcare professionals, and what the gap would be in 2035 and in 2050. The current status of the physicians is that they work longer than you would expect, and certainly longer than what physicians necessarily work in the United States. So the first model that we did looked at basically the current work practices of physicians. And one example is for orthopedics. We currently have in Puerto Rico a severe shortage of orthopedic providers. These are people, of course, that handle bone conditions and et cetera. We need twice as many orthopedic providers than we currently have. That is somewhat mitigated by 2035 because of the decline in the population, but the gap does not go away. Another example would be endocrinologists. Endocrinologists treat chronic kidney disease, which is a very prevalent disease within the Puerto Rico population. Here, we have a gap that is 140% fewer physicians, endocrinologists, than the island needs in order to care for that chronic disease population. And this increases significantly in 2021. We also looked at the model where we took the position that physicians retire by the age of 65 or become significantly less productive in the number of patients that they see. If you do this, the healthcare shortage gets particularly severe. So normal health practices tells you that the Puerto Rican economy, its workforce gap is severe. I will say that the gap, we believe, is probably underestimated by our projections because of accessibility and because of workforce practice. We think that we are being very conservative in these estimates, and this, as I said, that is probably more severe. With respect to nurses, I will say you are producing sufficient number of nurses, but nurses are almost 100%, once they graduated, leaving the island, or many nurses that stay here have decided to remove themselves from the workforce, either due to wages or work-life balance. We also did our analysis by geography. And this is quite important because the gap is not consistent across the island. In the metro area, for example, with gastroenterologists who handle the digestive system, the metro area, for example, right now has enough specialists in that area to take care of the population, but the northern part of the island and the western part of the island are seeing very severe shortage of physicians in that practice area. Endocrinologists is very similar. In fact, it's even more severe as we look at people who are able to care for chronic kidney disease. If we go to the next slide, we look at the time spent in outpatient settings versus in-hospital settings. And we find the workforce practices on the island are such that our physician workforce actually spends more time in outpatient settings than they do in hospital settings. It's about 90% or so in the outpatient setting versus in the United States where it's about 80%. This actually exacerbates the shortage of workforces and the burnout of the workforce that are actually providing inpatient care within hospitals.
So as Susan mentioned, the problem of access is compounded by a lack not just of physicians, but of nurses and other allied health professionals. As she was mentioning, we have enough trained and licensed nurses, but these nurses are not necessarily available to work in settings like hospitals because of the night shifts and other working conditions, which are much more stressful than what they would see in another type of job. This quote by a physician illustrates extremely well what the problem is and why it's compounded. In short, if we do not have enough nurses, if we do not have enough equipment, if we do not have enough allied health professionals, physicians cannot perform the procedures they need to perform at hospitals. That leads to further access issues, and it also leads to severe losses both for hospitals and for the physicians themselves, compounding the problem.
I'll take on this one, and again, we're not trying to paint a picture that's so grim that people just want to, leave the building and jump out of the building, but we got to paint the picture the way it is. There are deficiencies also in workforce sectors that are not usually seen as being core to the healthcare system. They are, I guess you could say, supportive of the healthcare system. We're talking about security personnel. We're talking about environmental services. You need staff in hospitals that can claim beds so they can be actually used. Transportation, access to transportation, not just for the patients, but in some cases for the employees themselves, and then child and elder care. Through the interview process, we heard repeatedly that a lot of staff, whether in physician offices or hospitals, sometimes have to deal with the challenge of child care, or they have an elderly family member that they need to take care of too. And the tendency is that in a family that has an employee that works in healthcare, that employee is the one that actually takes care of the elderly, frail family member. So it compounds the problem in terms of the availability of that personnel to manage or deliver healthcare services. And as Maria noted, and perhaps not surprisingly, in hospitals, in very stressful settings, and in late shifts, this becomes a more exacerbated problem. We even heard stories about staff that work at a particular hospital that I won't name that have to park about 30 minutes away from the hospital itself, and then have to wait for a bus in the middle of the night to actually get between the parking location and the hospital. These are challenges that these same individuals, if they were to relocate to the United States, they probably wouldn't have, not to mention the fact that they'd be paid more. So these are issues that might not be specific to the healthcare workforce and them being there to work, but they impact their ability to work, so we gotta consider them as well.
One of the things that we looked at was the administrative burden over the physicians and each one of the providers. So when you look at the time, we did the survey to the provider and we asked them how much time they spend doing service directly to patients versus administrative. One of the things that we found was that there's a lot, even though they have the same federal requirements as the United States, even though they have a lot of processes, in Puerto Rico they're faced with two important challenges that increase the percentage of administrative burden over a physician. One is the bureaucratic, the licensing issues that they have with regards to managing their credentialing, their licensing process, and some of those burdens that are more acute here in the island. But then also the technology access, so how much facility and infrastructure they have in their office, and what staff do they have available that can manage the administrative staff versus the physician. We heard stories of surgeons that would have to do a lot of the actual paperwork before the surgery or after the surgery, which is usually provided with a more middle, lower level support system that currently does not exist in Puerto Rico, including nurse practitioners, physician assistants. So that model that has increased and has evolved in the United States we're still behind there. So you'll see here some of the percentages of the time spent by physician administrative tasks, the licensing cycle, 3 months, and how much that is a challenge, and then the credentialing over time, which also creates an additional burden.
One of the critical factors impacting the access problem is the lack of care management and inefficiencies in care. What I mean by this is because we have fewer resources, those resources are taking care of our sickest patients. Puerto Rico has one of the highest emergency room utilization rates in the nation. What that means is that people are getting their chronic diseases addressed in emergency rooms. And emergency rooms were not designed to address those needs. What happens when a patient goes to address a chronic disease in an emergency room? They will come back because the disease was not addressed. And that is something that can actually be improved significantly in a short period of time. As Susan mentioned, some of the highest needs are for those chronic conditions. We need more nephrologists, more endocrinologists, because our population is sicker. And as the quotes here show, everyone within the system is seeing sicker patients. The patients showing up at the emergency room are sicker. The patients showing up in the hospitals are sicker. So we need to be able to reverse that trend. This is one of the areas that I mentioned has significant potential to have a quick, and when I say quick, it could be something within a year, where we can start seeing increased access. And that can be done by developing programs that actually reduce progression of disease. We've seen these programs in Puerto Rico. One example is Hospital General de Castañer. They received funding from the Health Resources and Services Administration to develop a pilot project which uses telehealth in the mountains in the area of Castañer to actually address the needs of patients by sending community health workers out to their homes. The result, we are seeing these patients improve in their diabetes and hypertension metrics, and the overall cost for these very sick patients is a 72% cost reduction. So opportunities exist. Another one of the areas that was mentioned is the opportunity to do something called specialty consults. Specialty consults is when we reimburse specialists to consult to primary care providers, which are available to better manage chronic diseases. As Susan mentions, 80% of spending in healthcare is around chronic diseases. So this is a big area of opportunity, and investment in innovation is critical.
Now, to make all this happen, to be able to get to a place where we are coordinating care more effectively and actually treating the underlying causes of disease, you gotta have information. Providers have to have better access to information. They have to have complete information about their patients, their entire history, if at all possible, so they can make informed decisions. Let's face it, in Puerto Rico, that does not happen. We do not have in Puerto Rico, after tens of millions of dollars invested in technology to provide interconnectivity amongst providers through electronic health records, that does not happen today. So individuals have to literally carry their records from provider to provider to provider, and some providers don't have access to information, which can lead to medical errors. It can lead to excessive orders of tests and procedures, and all of this drives cost, not to mention the impact that it has on outcomes. This is also the jurisdiction in the U.S. that has the lowest adoption of electronic health records in the United States. There's still a lot of providers billing on paper. There's still a lot of providers charting on paper, and what that does is it adds to the administrative burden of the provider, which means they have less time available to actually work with patients. So improving the underlying technology infrastructure that these healthcare workforce operates in is gonna be critical to enable the coordinated care that Maria described and ultimately bend that cost curve and bring costs down, particularly for those sickest patients that have to be seen and require collaboration across multiple providers for them to receive effective care.
One of the things that I would highlight, and I know that the the current administration has spoken about this, not just last year, but currently in the last couple of months, is how do we work with laws and regulation that adversely impact healthcare workforce supply? For example, how do we expand the limits that we currently have with access to telehealth so that we have telehealth providers that can give telehealth services to patients in Puerto Rico? How do we reduce the limits of use and scope of practice for physician extenders, nurse practitioners, physician assistants? How do we find a way to innovate our regulations that right now create create burdens, protectionists, and limits the ability to access or to support the current providers that we currently have in the island that are doing everything they can to provide services. And I know this is something that we've heard, the incoming government talk about that, as well as the incoming Secretary of Health. And I think this is an area that we can look at. We met and we looked at all of the laws and regulations. And then here, quickly, just highlighting the fact that we have, sometimes there's unintended consequences to certain policy initiatives. And we'll briefly talk about two. For example, we know that the payment model is not adequate to support our, provider healthcare network. However, by increasing the reimbursement rates for one line of business, Medicaid, by increasing the Medicaid rate increases, it created an adverse effect into the commercial side of the business. So physicians have right now there's limited access to physicians for individuals and commercials that are outside of the Medicaid, Medicare Advantage plan that are in the commercial, which is our working class, our small business owners and then that increases an increase in obviously premiums over commercial side. And here you see also the fact that the tax incentives that were implemented did retain the providers in the island. We looked at the data and we also, of the licensing for the past 10 years, but we also did a survey and more than 92% of the physicians that took the law, incentive law, were already in Puerto Rico. So obviously it supported their practice, but it didn't have the effect of necessarily of the bringing new physicians into the island. So we talk about some of the recommendations of how we create incentives that focus more on making sure that we support those new doctors that are coming in, either recently graduates that are coming in the first couple of years.
With respect to training, we do have to commend academia for its efforts to produce high-quality residencies. This is actively happening, and we are seeing expansion. However, we need to look at the problem from a broader perspective. On the one hand, our highly trained physicians and nurses who obtain on-the-job and robust training are being actively recruited by other states where they have better benefits, better pay, and what they do very well is make sure the licensing and the credentialing is available the day the graduate is done with their education. That is what we are competing against. And as Annie mentioned, and our graph shows, our folks are waiting 3 months without any revenue after they graduate because they can't get the credentialing and the licensing. So that is a big issue with respect to retention. At the same time, there are other programs that do not have residencies. Some of these are for general physicians, some of these are for nurses. And what we are hearing from hospitals and primary care providers is that once these providers are recruited, they take a lot of training, which increases the costs of practice.
So we say funding for last because it tends to be the most controversial subject. And it is clear, and it is beyond well documented, that Puerto Rico does not have the same level of funding for healthcare services than the typical state has. And we don't want to get into that here. But I would echo what Executive Director Mojica said earlier about in an environment where you have constrained funds, you have to make difficult decisions about how you allocate the funds and how you justify the use of those funds and how you coordinate initiatives to take maximum advantage of those funds. We have some recommendations coming up related to that. But it is without a doubt that the funding challenge creates some of the unintended consequences that Annie described before. Providers obviously are going to look to maximize their revenue to stay in business. And they might gravitate towards the program or the payer that actually pays them the most, which can create then imbalance in terms of access to services. So we recognize that funding is a challenge, and we should, of course, continue to lobby for additional funds. An argument that I've made in conversations with my colleagues here is, and hopefully this is something that a congressperson will understand, if somebody lives in Puerto Rico and decides to move to the U.S., the Medicaid program that actually takes on that individual will have to spend 3 times more on that individual than what they spend in Puerto Rico. So it would behoove, one would think, Congress to allocate more funding for Medicaid in Puerto Rico to prevent that from happening. That is the kind of argument that we should be making to Congress, but at the same time, we have to make the most of available funds to better make the case for additional funding. So funding is complicated, we know that, but we should first focus on how we can make the most of existing funding so that we can more easily make the case for additional funding. And that leads us to recommendations. And this might be a little hard to read, but we bucketed recommendations into these 8 categories. And we should start by saying that while we know we presented a picture that's less than positive, it is not an impossibility to address these challenges. We believe that we need to, though, focus on 2 types of initiatives. We have to address the demand side of the equation, while we also address the supply side of the equation. The recommendations that will be focused on demand should be focused using the old Pareto rule of early interventions on impactable health issues and smarter use of healthcare resources so that we're targeting that 10% of the population that consumes 80% of the healthcare resources. And as it happens, as both Dr. Manning and Maria noted, those conditions, for the most part, are impactable. You can prevent chronic kidney disease. You can address or prevent diabetes. You can hopefully address asthma and other respiratory conditions before they become severe, and then you gotta be stuck with a can of oxygen. These are controllable, impactable conditions that through better coordinated care, where you bring primary care physicians, specialty physicians, insurance companies and hospitals together, you can drive down the cost of care, as Maria noted. So all of these recommendations that we're talking about that relate to demand are focused on addressing those impactable health conditions and making smarter use of available resources to improve coordination. On the supply side, we got to look at all the factors that drive supply. We got to look at the quantity, and we got to raise the quantity of particular providers. We got to address availability, make sure that they are open for more hours. We got to address capacity so that when they're available, they can actually see more patients and not be submitting bills or documenting or spending time on administrative stuff that they shouldn't be spending it on. And we got to make the provider more accessible to the patient through telehealth, through opening more locations in the parts of the island that are more underserved and encouraging that so that they're not all pulled in San Juan and Bayamón. And we have to ensure that these supply initiatives are looking at what the demand is going to be 10 years from now. We cannot chase current demand. We got to look at what demand will be in the future because a lot of these programs take time to be implemented. So with that, we came up with these 8 categories of recommendations around more targeted condition, financial and tax incentives, around increasing supply through the liberalization of laws and regulations that Annie alluded to, make it easier for providers to offer telehealth services, for example, establish greater coordination of workforce development programs because, again, the funds are limited, so we got to make the most of those. Re-engineering administrative process so that a provider doesn't have to wait 6 months to get licensed or a year to get credentialed by an insurance company. Those coverage and payment policies that encourage coordinated care. Let's invest in critical healthcare infrastructure. Long-term care, as an example, is sorely needed in Puerto Rico. And in the United States, Medicaid is the primary payer of long-term care. So if Medicaid covers the service, the supply will come. You gotta have the funding so that the supply is realized. And again, we're gonna make some challenging decisions about how we allocate the funds, and we gotta make sure that every opportunity for healthcare funding that's available is pursued. There is unfortunately a history of Puerto Rico missing out on federal healthcare funding opportunities for a number of reasons. That cannot happen in the future. We gotta avail ourselves of every dollar of federal funds is available. And with that, I turn it back to Arnaldo.
Oh, thanks a lot, Gobernadora. Mucho trabajo que tenemos por adelante. So anyway, thanks for the FTI team for the report. Obviously, this is the first step in addressing some of these gaps. It's been a challenge to address them because we didn't have the data. So this information allows us to be more strategic and more specific. Not all gaps are the same. Not all the gaps are the same within the island of Puerto Rico, so we need to be strategic with the limited resources that we have. And although the picture is grim, there are things we can do together with the government that are what many people call low-hanging fruit to start addressing some of these gaps. And we are, with the next step of this process is we are going to be meeting with the government, with the chief of staff, and with the Secretary of Health and the team to start working on how we go about implementing, how we go about sequencing some of these recommendations, and we can start closing these gaps so we can have a stronger healthcare system. So, Mr. Chairman, Mr. Executive Director, we finish here with the report of FTI.